Okay, so primarily ECG correlation of MI. Here you can see the different lead systems and the different territories which are already depicted there. The priority is the LED territory. Always look from V1 to V6. If in V1 to V6, always look for T waves, the ST segment, the QRS waves predominantly. QRS is prolonged. You should think of bunda branch blank or left main disease or long standing MI, and there is absolute scar formation. There is ST depression with T wave inversion. There is a high chance that it may be heart attack of other region and causing a reciprocal changes in the anterior territory. Then suddenly directly go for the reciprocal changes of the ST elevation of the other regions like 2-3 AVF, only inferior, like the opposite leads will be having the reciprocal changes. If lead 2-3 AVF is ST elevation is there, the anterior leads will be having ST depression. If the anterior leads are having ST elevation, lead 2-3 AVF will be having ST depression, that you should be looking for. So if the ST elevation is there with T wave elevation, the hyperacute T waves, then always go with the anterior territory MI is happening. So V1 to V4 or V5, V6, the larger the territory is involved with AVR elevation, most probably we are dealing with left main or left anterior descending osteoproximal disease. If only V1, V2, V3, V4 is elevated, or only V2, V3, V4 is elevated without reciprocal changes in 2-3 AVF, that is no depression in 2-3 AVF, and there is no elevation in lead 1 and AVL, then most probably you are dealing with disease of the LAD territory distal to the diagonal. So distal to the diagonal will be sparing lead 1 AVL and lateral leads, and there will be no AVR elevation, and the root 3 AVF reciprocal changes will not be there. In that case, it will be mostly distal to the diagonal. If it is proximal to the diagonal, most probably LCX, the lead 1 and AVL will be elevated, and lateral leads will be elevation will be there, and there will be 2-3 AVF depression. 3 more than 2 depression will be there. More than 2 mm is what is taken as significant in 3, and 2 AVF more than 1 mm is taken as significant. So this is the LAD territory, that is left anterior descending. In fact, if only isolated V3, V5, V6 elevation or ST elevation or ST depression is noticed, then look for lead 1 and AVL. If the lead 1 AVL are also depressed or elevated, most probably you are dealing with LCX or big diagonal, ramus, LCX or big diagonal you are dealing with. Most of the time it's the LCX territory, in fact, which we will be seeing L5, LV6. Isolated V5, V6, we can get a diagonal, good diagonal disease can cause V5, V6 ST elevation or depression. If the lead 1 AVL with V5, V6 is there, most probably we are dealing with XLs and the LCX and diagonal branch, that is LCX is non-dominant LCX. If we are dealing with lead 2-3 AVF, 2-3 AVF elevation is there, and then lead 1 V2, V3, V6 there, like we can see here depression is there, then most probably and obviously you are dealing with the infia wall MI. Infia wall MI can be caused by the dominant RCA or dominant LCX. If the dominant RCA is there, lead 3 will be elevation will be more than lead 2, because we already discussed the axis. Lead 3 AVF is more towards the right coronary artery, so right coronary artery is involved. Lead 3 and lead AVF will be having more elevations than the lead 2. If the LCX territory involves, lead 2 will be having more elevation than the lead 3 and AVF, and approximately, and also there will be a lead 1 and lead AVL elevation, and also slight lateral lead elevation will be there. So in this case, if you can focus correctly, actually lead 2 is more elevated than lead 3 and AVF, and actually there is slight elevation in the V5 and V6, and there is a huge depression in the V1, V2, V3. V1, V2, V3 depression signifies there is a posterior wall involvement also. If it were to be a dominant RCA with the proximal occlusion of the RCA, then usually V1 will be isoelectric or V1 elevation will be seen. That is very important thing. If you are suspecting proximal RCA, V1 elevation is one of the most important thing, and lead 3 will be hugely elevated, ST elevation in hugely elevated in lead 3 than the lead 2. So going by this ECG, it's most probably the LCX territory. Most probably LCX is the dominant territory. And also look for the PR interval in all the infia wall MIs. If the PR is prolonged, then most probably we are having a defect in the AV node. AV nodal artery is the PDA. PDA is gets blocked, then conduction through the AV node decreases, so then the PR prolongation will be there. There will be sinus bradycardia or even first degree AV block, then second degree, and even complete AV block may be there depending on the severity of the ischemia. Thanks.